First of all, is pregnancy risky to the health of a woman with ET and JAK positive?
Yeah, I mean, a couple of things to consider, right? So there is a risk of miscarriage. The data seems to suggest that there isn't necessarily an increased risk of complications to the mother. One of the things we always worry about is that pregnancy is what we call a prothrombotic state, that it automatically increases the risk of having clots in pregnant women. The JAK2 mutation, it's a little bit controversial because there is one or two studies that say that it doesn't have any association with adverse outcomes in pregnancy, but there are some other studies that say that it does. And so in my mind, given that we know that JAK2 already is a risk factor for blood clots in patients with ET to begin with, it is a little bit of a concern. So one of the things that I always advise is that if somebody is pregnant or going to become pregnant, they need to be under the care of A, an MPN specialist who deals with pregnancy, because not all of us do, and B, they need to be under the care of what we call a high-risk obstetrician. This is a person who has training in maternal fetal medicine or other board certifications where they are well equipped to deal with high-risk pregnancies, not just regular healthy pregnancies, but high risk. That is absolutely vital if somebody has an MPN and is pregnant.
No, I think that was a wonderful answer, and I think we've heard about some wonderful babies born to our patients with MPN today, so I think the outlook is good.
And the irony of this question is there was a gynecologist who is a patient who was present yesterday, and she is going to partner with us to start speaking at these events and work with us to help all of you. The second part of this question, which I think is equally, they're all important, but this is very important. Will my pregnancy or will a pregnancy increase, will the disease progression be more prevalent?
I'm not sure that I know that there's any data to suggest that. I think one of the things that can confound that is that there can be fluctuations in blood counts as a result of pregnancy normally. And so, we heard the story about the platelets going up after pregnancy. Is there a clear relationship? I'm not aware that there is any data to suggest that the pregnancy itself can cause a disease progression.
Some patients even feel better when pregnant. You get a little expanded plasma volume, the hemoglobin goes down almost all of it. So you have patients who actually feel better. Because pregnancy and after the babies evidence of disease progression
This question used to be asked all the time, so it's interesting to see it again. Does the increased allele burden of JAK2 increase the risk of progression?
In older patients, we do see that the allele burden tends to rise with age, and the risk for progression is associated with age. Our younger patients, as you saw, have very flat lines for progression and for allele burden. So I think in an older patient, there probably is a relationship.
Can read this correctly. Their 16-year-old daughter has ET initially at counts of 22 million, started aspirin, was taken off due to von Willebrand's concern, now has platelets at 600 to 800,000. What is your thought on taking baby aspirin again?
So I think the main reason people get taken off aspirin is because of the bleeding risk with acquired von Willebrand. And we tend not to see acquired von Willebrand usually when your platelet counts are below 1 million. So I think if aspirin is otherwise helpful for your symptoms and you don't have the additional bleeding risk of acquired von Willebrand, I think in those situations it's usually fine to be on aspirin. I think it's when you get into the situation of if your platelets are back up and your VW levels are dropping, that's when you're at risk of more serious bleeding, so then aspirin on top of that is maybe a concern. But we've certainly had patients who are on aspirin, and as long as they don't have acquired VW, we don't usually see increased bleeding from the aspirin alone. People take aspirin all the time, so.
Yeah, that's exactly the approach we take.
Their current pediatric hematologist wants to remove hydroxyurea and only use interferon due to the total bilirubin levels at about 2.2. Is there concern about liver health related to hydroxyurea?
Yeah, we had one patient who developed it with interferon. A patient could have a side effect that we haven't seen before. So the one thing that could be tried for that patient is to stop it and see if the transaminases improve. In fact, that's what we did with our patient. Because he had had a liver transplant, the concern was first rejection, and when that was ruled out, we thought, well, the alpha interferon could be the next thing, and when we stopped it, his improved. So that could be tried. It's not certainly something we see very often.
And I think, I think high bilirubin and high, liver enzymes like transaminitis is a little different sometimes, and we've seen some kids get, a transaminitis with hydroxyurea, but it's not dangerous per se, and it does go away. High bilirubin might be a little different, and that may be something that requires a little more digging into to sort of better understand why that's happening, because then you start to wonder about, gallbladder and blockages in the liver and things. So I always think of bilirubin, a direct bilirubin, if it's direct, a little differently than sort of liver enzymes per se.
Yeah, I agree 100%. It sounds like this patient should have their liver function tested more fully, and then looking for other causes for that as well.
Okay, if fibrosis is found during a bone marrow biopsy on a ET patient that's JAK2 positive, is there an increased risk for MF, and if so, how can that risk be monitored?
Well, it might change the diagnosis, so we have to think about that carefully, because now the landscape has changed where we have ET and myelofibrosis, but now there's something called prefibrotic myelofibrosis that lives in between those two things. In general, the data from both PV and ET does suggest that if there is increased fibrosis when the diagnosis is made, there is some higher likelihood that the disease will progress to myelofibrosis. It's not an absolute. Is there a reason to monitor it per se by doing bone marrows? I would say no. In general, at least our approach is that if there's a change in the blood counts or something else clinically with the patient, that's the time to redo a bone marrow, but doing it for the sake of doing it to know what the fibrosis score is, after the diagnosis is made, I'm not sure that necessarily needs to be done. That's my opinion.
And that's typically how we follow our patients, although I definitely agree with Dr. Kuchin. If a patient is on hydroxyurea, you may want to do more frequent marrows.
If a patient feels confident in their doctor, how advisable is getting a second opinion? If it is recommended, how soon should it be done?
That's a really interesting question. One should never be afraid to get a second opinion, okay? And that comes from two perspectives. A, this is about you getting more information. B, people worry, well, what is my physician going to think? The answer is your physician should encourage it and should never put up any barriers, because that's somebody who, let's not go down that road, but that is not a good sign. That is not something you want. And to be incredibly honest about this, right, and I'm a referral specialist. I see patients who come for second opinions. Have I ever sent somebody for a second opinion? Absolutely, because we run into situations where we don't all have all the expertise all of the time. And so have I sent my own patients to somebody else who might have seen whatever various aspect more frequently? Yes, it is a good thing, and it is an important resource. And I think that it's a personal decision, right? I think that if you feel like you have enough information, you're comfortable with your management, then you don't necessarily need one. But if it brings you peace of mind, it's absolutely appropriate.
And I agree 100%. Sometimes patients want to just feel more comfortable with the approach, and so I always encourage it. And also, as the physician caring, you like to have a consensus amongst colleagues who know a lot. And that's why these kinds of meetings are so important. We're already talking about trading slides and approaches and collaborating.
And I agree with everything that was said, and it's one of those things where for a lot of, these situations, especially with kids, there's not one right answer. So if your doctor has, said, if your doctor says to you, I haven't seen this a lot, but this is what I think we should do, that's not really helpful to you. But if they say, I reached out to a couple of people, I've looked in the literature, this is what I think makes the most sense and why, then that's great. And if you feel comfortable with that, that's fine. But if your doctor says, this is what I'm recommending, and, I don't like the alternatives, but you do, then that's what a second opinion is for, because you may get different opinions, and that's okay. It might be confusing as a patient to hear two different opinions, but it's good in some ways, because as long as people can explain to you why they think this is what they're recommending, why this is their choice for you, doesn't mean it's right or wrong. There's not one way to treat MPNs in young people. There's different ways. So you have to find what fits for you. So again, if your doctor is telling you something that sounds logical, that fits with what you've seen on, the interwebs, and, you feel comfortable with that, you don't have to. But if you say, I appreciate your honesty in telling me you haven't seen a lot of this, I'm going to go speak to someone who maybe has seen it a little more, just to put you at ease that kind of you're on the right path, then that's fine. There's not a rule about it. And as far as timing of it, I think probably sooner makes sense, just because if you're talking about potentially starting a therapy because you do have symptoms or did have a clot or do have bleeding, I think you would probably feel more comfortable doing it sooner rather than starting a medicine for 6 months and then going to see someone who says, I actually would recommend something else that you end up preferring. So I think in that sense, maybe doing it a little earlier would just be more useful for you as the patient and the family.
For males, what's the risk of sterility with hydroxyurea or other drugs?
I'm not aware that there's any risk of sterility. In patients who are getting intensive chemotherapy, we often have them do sperm banking before. These are people who have leukemia who we're going to treat with high-intensity chemotherapy. That hasn't been our practice with hydroxyurea. I don't know.
No, and the other thing with hydroxyurea is that we usually tell people it's not ideal to take it if you're trying to father a child or become pregnant, because we do know that hydroxyurea can have a risk for a fetus. Even though it's very healthy, very safe to give like a 6-month-old baby, you don't want a fetus to be exposed to hydroxyurea. So I don't think we have clear data that it causes sterility. I think it's something, though, that if you're taking it as a male and you're family planning at some point, it would be reasonable to speak to your physician about alternatives at that point if you know that you're going to want to father a child.
Yeah, and another patient population that takes a fair amount of hydroxyurea are sickle cell patients. And so we always counsel them, or we tend to counsel them, if you're deciding to start a family, for both men and women, we typically have them go off of it for a few months.
Is there a way that diet can help control the disease?
That's a pretty common question. And the only advice I usually give patients is that we talked about lifestyle modification, right? That's an important part of managing your disease. And that is something, you as a patient have the power to control, right? So I think that, a normal, healthy diet, what does that mean? I know that keeps changing what that definition is, but I think that is the most important aspect in terms of watching your sugar intake, cholesterol intake, those types of things. That is the only real advice that I tend to give with regards to that, because I just don't think we have really robust data to suggest this diet or that diet might be better.
Yeah, I agree. We just recommend a healthy diet for all patients, the patients and their family members.
Can I plug something? So in late October, the gentleman back there, the videographer, will be coming to my home. Kathleen and I did a lot of research on foods and herbs and spices that promote blood flow and just bring some better health to one's body. And so we're just going to start putting these little recipes out there, and they're good. They're really good. So anyway.
We're happy to be.
Yes. Ann Crocker, call me. Okay, so this one, I think the question is, we hear that a bone marrow transplant. This says biopsy, but I think you meant transplant is a cure for MPN. And has there been any discussion about when you should have one? And that is another area that, Michelle, we're partnering on some stuff.
So when to have a bone marrow transplant, that is a tricky question. It is a very difficult question, and I have this conversation so often with patients, typically older patients who are kind of coming close to the age where we don't do transplants. At MSK, we stopped doing them around age 75 or 76. But as an example, I have somebody who is 75 now, who's on a clinical trial and doing fantastically. And the question is, well, should I have a transplant or not? And the problem with that is two things. One is that, is a transplant a guaranteed successful outcome? It isn't. We have to be realistic with that. Does it cure everybody? It doesn't. Is there a risk of real toxicity from a transplant? There is. And we have to weigh that versus, what is the other aspect, which is that the transplanters like to say, you're never younger than you are today, you're never healthier than you are today, so why not do it now? At the end of the day, we don't have a crystal ball, and that's what makes these things very difficult to say this is the right time or next year. I think that it's a much more difficult question in a younger patient. At least, with an older patient, we can say, look, this is the window, and if the window closes, we can't do the transplant, and so sometimes that forces our decision. But I think in younger patients, it's a more difficult question.
Yeah, and if you recall those nice curves that we saw for our pediatric patients, they're doing great. So they're doing great throughout their entire childhood and their early adulthood. So to put them at a risk, a procedure that has a 5 or 10% mortality, as some transplants, depending on the type, it's a hard recommendation to make, because we can say there's an almost 100% chance you're going to have a healthy childhood, a healthy early adulthood. So it's a significant risk at this point.
Yeah, I agree. Transplant is very much not a benign process. And I mean, you can speak to anyone whose child has been through a bone marrow transplant or who has been through one as a young person. It's a big deal. And so while it is theoretically a cure, which is very appealing, it is not without a lot of risk. And, ethically as a physician, I have a very hard time wrapping my brain around referring someone for transplant when their symptoms might be fairly well controlled on a medication that doesn't have a lot of risk. The other thing I'll say about transplant, usually the best outcomes are with a matched sibling donor, and a lot of kids don't have that. So if you don't have a matched sibling donor, the risk of doing a transplant, pretty much for anything, is always higher. So it's a very complicated question, and I think, is there any reason why, if your child's diagnosed, that you couldn't just, get your sibling, his or her siblings a cheek swab? Sure. Just so you know in the back of your mind what options you're starting out with, that's not unreasonable. But I think to recommend transplant to a child or adolescent as a physician, I think I have to feel very strongly that their disease is bad, and that I think that the risk of not doing it would have to outweigh the potential risks of doing it, because it is such a potentially risky endeavor that, while in theory usually works, there are people who fail transplant. Excuse me. So it's definitely not something I would take lightly, and I don't recommend it often, because I think it's usually more risky than not.